Let's talk about fellowships. What is up, Zach here with Dr. Eyeball MD. Welcome back to my channel. If you are new, we talk about everything from medical school, getting into residency, getting into ophthalmology, fellowships, all that kind of stuff, and all the other weird stuff that I like to just ramble about. So in today's video, specifically what I want to go over are the fellowships that you can go into out of ophthalmology, kind of the upsides and downsides to each of the fellowships. Now, keep in mind, this is through the eyes of a new third-year ophthalmology resident. So I obviously don't have any experience practicing in any of these fellowships. And so this is going to be through my kind of rose-tinted glasses at an academic program, just what I've witnessed, to be the upsides and downsides of some of these specialties. But in the end, that's not a terrible perspective to have, because if you are in ophthalmology, you're going to have to make the decision on going into one of these fellowships with the same amount of information that I am presenting to you here, just because you won't have practiced in any of these fellowships or any of these specialties either. So you'll be operating on probably a similar amount of kind of experience by the time you have to decide if you're going to do one of these fellowships. So I'll just kind of touch on some of the superficial highlights and superficial weaknesses of each of these specialties that I've noticed. This is obviously going to vary by practice setting and, just your kind of setup out in the private world. So depending on what your setup is, whether you're private practice, academic, it's going to vary some, and it can vary a lot just between practices and kind of how things are structured for your practice. But by and large, I'm just going to touch on some of the upsides and downsides to some of these fellowships, some of these subspecialties within ophthalmology that I've noticed. So let's start with the outside and work our way in. So let's start with oculoplastics. Oculoplastics, upsides to oculoplastics. They're fun surgeries. They're just kind of fun surgeries to do. You're operating around the eye, more so operating on the eye, and you're not operating within the eye. So you're operating on the adnexal structures around the eye. You're in the orbit. Sometimes you branch out around the face. You do face lifts, neck lifts, that kind of thing. Sometimes you'll do a lot of cosmetic stuff. You can do a lot of cosmetic stuff. You can do upper and lower lid blepharoplasties, ptosis. You can do Botox, fillers, all that kind of stuff on the cosmetic side, but you can also do a lot of functional surgery. So it'll be like ptosis will be more functional typically. You can do big orbital surgeries. You can do things, like tumors, and so you can have more of the medicine side of it. It's not all cosmetic. So you can split it up. You can do functional, you can do cosmetic, you can do big orbital stuff at academic centers, that kind of thing. So overall, the surgeries are pretty cool, and there's a lot of breadth to it. They can be pretty different. You get kind of breadth in what you're seeing. So as opposed to something like comprehensive, where you may just be doing phacos and cataracts all day long, there might be a little more variety in oculoplastics. That being said, if you're just out doing a lot of cosmetic stuff, you may just be doing a lot of blephs and ptosis and, cosmetic stuff like that. So maybe less breadth there, but I feel like there's opportunity for a little more breadth than you may get in some of the other subspecialties, a little more variety and kind of things just being a little more different from case to case, if you like that kind of stuff. Also, upsides of it are it's one of the more I guess artistic subspecialties within ophthalmology. It requires a little more kind of like visualizing outcomes in your surgeries before you do them. So it's a little more like just being it's a little more artistry involved with it probably than some of the other subspecialties that may be a little more technical in terms of the surgeries themselves. So if you like that, if you like, getting to kind of instill some sense of beauty or some sense of artistry in someone, in their face or around their eyes, oculoplastics is good. Overall, the call is pretty good, as long as you're not doing a lot of face call or trauma call out in private practice. It's pretty good. Most things can wait till the morning. Most lid lacs and things like that can be repaired next day or something like that. So you're not dealing with kind of the emergencies that you might be dealing with in something like retina, in terms of like endophthalmitis, retinal detachments, MAC on RDs, and things like that. So those are kind of some of the high points. Downsides to it, you're giving up operating within the eye, and that's something that you really have to decide if you're okay with doing that, if you're okay giving up cataract surgery, intraocular surgery. There are some instances where you could do both. I know 2 people personally that do cataract surgery and oculoplastics. But by and large, if you go the oculoplastics route, you kind of give up intraocular surgery. That's the biggest downside to it. Okay, next, cornea. So upsides to cornea. There's a lot of cool refractive stuff in cornea, and I feel like, at least in academics, the cornea guys kind of become the go-to guys. I think my mic's clipping a little. Let me turn this down. The cornea guys are kind of like the go-to guys for the more complicated cataracts, the more complicated anterior segment stuff. You get to do the transplants, you get to do the DMEX, the DSEX, if you like that kind of stuff. And sometimes the cornea guys are just the more, the people that other ophthalmologists will refer to for refractive things and more complicated lenses and things like that. So if you like the idea of doing that, that might be one benefit to doing cornea. Downsides, you're not really doing much in the back of the eye. So if you have any interest in retina or anything like that, then you're not going to be doing that with cornea. Some of the other downsides, you're dealing with a lot of the patients like dry eye. A lot of the more, at least in my opinion, more like boring things in ophthalmology, like dry eye and meibomian gland dysfunction, all that stuff. It's just not that exciting, not that sexy. But you can build practices around dry eye if you're into that kind of thing. I'm just not. So that would be, at least for me, one of the drawbacks to it. It's just a 1-year fellowship too, so it's a shorter fellowship. And I sort of mentioned with oculoplastics, it's going to be 2-year fellowship if you decide to go the ASOPers route. There are some 1-year oculoplastics fellowships you can do as well. There's a handful of those out there. Okay, moving on from cornea, let's do glaucoma. Upsides to glaucoma, there's a good job market for glaucoma right now, and you can do pretty well financially with glaucoma. There's not a ton of glaucoma emergencies unless you happen to be in our county clinic and seeing NVG on a regular basis. But out in the real world, glaucoma emergencies are not as frequent as some of the emergencies in the other subspecialties like retina. Some of the other upsides to it are you get to still do phacos, and I should have mentioned that applies to cornea too. So you're still doing phacos on top of the cornea surgeries. You still are doing cataract surgery. And same with glaucoma, you still get to do cataract surgery. You still can do refractive type surgery, LASIK, PRK, all that stuff. With glaucoma, if you wanted to, you could kind of work that into your practice. So on top of your glaucoma surgeries and managing glaucoma, you can still do phacos. So the upside to doing phacos and cataract surgery obviously is it's fun, and you get really happy patients because you can really improve their vision. So that's a big upside. On the flip side of that, for glaucoma, with glaucoma itself, barring the phacos and the cataracts that you do with it, you're not getting vision back in terms of doing a glaucoma surgery. So you're trying to stabilize or lower a patient's pressure with whatever you're doing, and you're not gonna go away, Mindy Pickles. You're not going to get vision back. You're going to be salvaging lost visual field, basically, and damage to the nerve with glaucoma. So it's kind of a salvaging game, sort of like retina can be that way too. It's kind of just a game of catch-up sometimes, a game of salvaging what you have. So in a way, that can be kind of refreshing, maybe to some people, because it's a little less, I guess, stressful, because you can just kind of explain to the patient that our goal here is to maintain and to prevent further vision loss, not to bring vision loss back in terms of the glaucoma surgeries. So anyways, glaucoma is super chill. I feel like good job market, overall good specialty, good subspecialty, 1-year fellowship, and it's not super highly competitive out there in the fellowship world. So if it's something you are at all interested in, I would consider looking into it. And then comprehensive ophthalmology, that's going to be what you just do straight out of residency. So you do your 3 years of ophthalmology residency, and then you are a comprehensive ophthalmologist. You can go straight into practice. You can do a lot of the stuff that these other subspecialists do. You can do some of the basic plastics procedures. You can really do what you're comfortable with. You can do ptosis, you can do blephs, you can do some of the cosmetic stuff, the Botox, that kind of stuff. You can do LASIK, PRK, stuff that the cornea docs would do too. You're probably not going to be doing a lot of corneal transplants. You're probably not going to be putting in tubes, but you might be doing MIGS, some of the smaller minor glaucoma procedures. You can do that with comp. I know people who do that with comp. And so you can do a lot of that stuff and not have to do the extra training. That being said, in a world where everything is becoming more and more subspecialized, you may lose a lot of that stuff to the subspecialist. And if you're looking to get a job in a more competitive job market, somewhere like a city that's already densely saturated with ophthalmologists, not having the subspecialty training, not being, glaucoma trained or cornea trained, may potentially make it a little harder to get a job as a comprehensive ophthalmologist in a saturated market. So that would be one potential downside to comp. One of the other upsides to doing comp is that you can essentially refer things out. So if you don't feel comfortable managing, the really complicated or end-stage glaucoma, you refer to the glaucoma person. Or if you don't, for the Fuchs, the patient needs transplants, corneal ulcers, all that stuff, you send to cornea. The retina stuff, obviously, the MAC off, the MAC on, whatever, the retinal detachments, you're going to be sending to the retina specialist. So it can be nice in that way, in that you can kind of send things out, essentially, and you don't have to manage all that. So if you want to be kind of the cataract guy, you're doing the cataract surgeries, and you're sending out all the other complicated stuff, you want that to be kind of your practice setup. That can be a really nice thing with the comp. However, if you are, out somewhere more rural with comp, you can do a lot of the stuff that the subspecialists do. You can do injections, you can do lasers, in terms of like PRP and that kind of thing. You do the YAGs, you can do the SLTs, all that, LPIs. You can do some of the glaucoma surgeries. You can do the MIGs. You can maybe even do some of the tubes. You probably won't be doing the retina surgeries, but you could be doing some of the strabs that the peds guys would maybe normally do if you're out somewhere really rural where you're like the only person, in a wide catchment area or something like that. So it has the opportunity to give you a lot of breadth in your practice, but also at the same time, that kind of depends on the saturation of the job market that you're in. So if you're in a city or something, you're probably going to be referring a lot of those subspecialty things to the subspecialists so that you don't kill your referral base for the cataracts, because you don't want to kill your referral base for the cataracts. You want them sending you the cataracts, and then you send them the subspecialty stuff, that kind of thing. Okay, so let's do uveitis real quick. So uveitis is typically a 1-year fellowship, and a lot of times people will combine uveitis with a retina fellowship. The benefit to doing uveitis is that it's not something that many people do, so it can make you kind of a lucrative commodity out there in the job market, especially if you're looking to go into something like a retina practice. If you can combine the uveitis, if you're going to be the uveitis guy, if you can have that kind of to add, it can help you get a job. At the same time, you often do need to do that retina fellowship if you want to be operating, because one of the downsides to uveitis is that you're not learning new specific uveitis type surgeries or anything like that. So it's going to be basically some other type of surgery that you're doing, and that's typically retina. So you have to do the retina fellowship if you want to be operating. If you want to be able to take surgical retina call at a practice, which they're going to want you to do, most likely if you're going to join a retina practice, you need to have that retina training in addition to the uveitis. So that's kind of maybe a downside, and then you're looking at 3 years there of extra training. But it does make you kind of, even more subspecialized, even more valuable if you have that uveitis training. And I feel like it can help you get jobs, academics and private practice. Another good thing to the uveitis is that if you like being more medicine-y and that kind of thing, it's kind of more that, because you're managing systemic issues. You may be managing a patient's cell septor, Humira, or Remicade. You may be kind of co-managing that with the rheumatologist, but if you like doing that and kind of being a little more like a medicine doctor, uveitis is probably one of the subspecialties that offers that the most. Let's do retina. So with retina, I think one of the biggest pluses, that's just cool surgeries. You're doing really cool surgeries. You do have your bread and butter stuff, your ERM peels, your macular holes, that kind of thing. But you get kind of more of the weirdness and the breadth in some of the surgeries, that similar to how you do with oculoplastics, of things being kind of very different and more variety, I feel like, than some of the other subspecialties in terms like glaucoma or cornea, or like comp with phacos and things like that. So you maybe get a little more breadth and variety in retina. You can see a lot of patients. You can have very efficiently run clinics. You can have that with any subspecialty, but I feel like the retina ones are especially efficient, and you're just doing the medical side of stuff. You often have really, really efficient run clinics with techs and scribes and that kind of thing. You see a ton of patients. You can do a ton of imaging. They make a lot of money often because they do a lot of injections. They do a lot of imaging that they can bill for. So that's an upside to it. You should get paid for what you're doing. So retina is a cool field overall. The downside is, it's a little more of you getting the emergency kind of things. So whereas a lot of the subspecialties like comp or maybe like plastics or something, you're not getting a ton of like emergencies and things like that. You can, there's a handful of them, but with retina, I feel like it tends to get more of that. So you get the endophthalmitis, you get the 5 p.m. Friday patient sent over with dropped lens or with endophthalmitis, something like that, MAC off retinal detachment or MAC on retinal detachment, that kind of thing. You get more of the emergencies, and I feel like retina is just overall a little bit busier. Again, that's going to come down to kind of how you structure your practice, but overall, I do feel like it is a little bit on the busier side often. Breathe. Okay, oncology. So oncology is a 1-year fellowship. Oh, and I should mention with retina, you can do 1-year medical retina or 2-year surgical retina. Most people do the 2-year surgical retina because most people want to operate. If you're doing medical retina, then you're primarily just going to be doing medical retina injections, lasers, things like that. You're not going to be doing the operations. So most people do a 2-year surgical retina fellowship. With oncology, if you want to do oncology, it's not something that a lot of people do, but typically it's a 1-year fellowship, and typically it will get paired with a retina fellowship as well. So you're looking at possibly 3 years there. The upsides to it is, you're going to be like one of the few people that does ocular oncology. It's not that common. So that can make you a little more lucrative commodity. Again, if you're looking for a job or something, if you're the oncology guy. Downside is, again, like some instances in retina and glaucoma, a lot of times you're just salvaging, and you're not getting great improvements in vision. You're kind of just trying to prevent patients from having metastatic melanoma and that kind of thing, putting plaques on and then getting radiation retinopathy, neuropathy, that kind of thing. So it can be kind of one of the less, I guess, maybe a little less satisfying in terms of like super happy patients, but also it is satisfying and that you can save people's life with ocular oncology, basically. So it's kind of a double-edged sword. It's not like 20/20 happy cataract surgery, but it is like, oh, well, I'm not going to have metastatic melanoma because you were able to help me. So look at that how you will if you want to do ocular oncology. Okay, neuro-ophthalmology. The upsides to neuro-ophthalmology is, again, not many people do it, so it can help you get a job somewhere if you're subspecialized in this. The reason I feel like most people don't go into it is because it's not a surgical subspecialty per se. So there are some surgeries you could do within that. You could do optic nerve sheath fenestrations. You could still do phacos and be the neuro-op guy. You could be plastics and also have neuro-op training, where I do residency. It's combined neuro-op plastics training, so you get both if you do a plastics fellowship. But because it doesn't have its own surgeries per se, and a lot of times you're a little more like a medical ophthalmology, and you may not be operating quite as much. So I think that tends to kind of steer some people away from it. And it may not pay quite as well as some of the other more procedural-based subspecialties. So take that for what it's worth. And then peds. I didn't talk about peds. So upside to peds is if you like kids, you get to work with kids. It's more or less fairly simple stuff. The patients aren't always quite as complicated. Surgery-wise, you're mostly doing strab surgery. You don't do a ton of intraocular surgery unless you're doing like pediatric cataracts. At least in my experience, the glaucoma subspecialists are the ones that are doing pediatric glaucoma surgery. The retina subspecialists are the ones doing pediatric retina surgery. So you're not typically doing that kind of stuff as the pediatric ophthalmologist, primarily doing strab surgery or eye muscle surgery to fix the misalignment of the eyes, put them back in a, ortho alignment in terms of surgery. Peds doesn't always get paid as much as some of the other subspecialties, so that could be viewed as a downside to some people. But I've seen where it can pay really well in certain instances. So take that for what it's worth. It's typically a little bit easier to get into in terms of fellowship, and it's a 1-year fellowship. So if you really like kids and you really like strab surgery and that kind of thing, it'd be a good subspecialty to do. Anyways, that's my take on some of these fellowships and subspecialties, just what I've noticed as a resident. Tell me why I'm wrong about these things down in the comments if you're out in practice, and you can tell me why I don't know what I'm talking about, because I'm sure in some of these instances, some people with more experience could speak better to this. Just giving you my impression after being around it for a few years. Hopefully that can kind of give you some insight into any of these things if you are considering one. Just kind of a broad overview of the subspecialties. We'll go into each one individually in more detail. I think I'll probably do a whole video on each of the subspecialties, and we'll try to talk to some of the fellows and attendings if I can get them to sit down and go over kind of more detailed about these subspecialties. Anyways, I hope that was helpful. Hope you guys liked this video. If you did, leave a like on it, comment down below suggestions for new videos. We're always coming out with new stuff. I'm Zach with Dr. Eyeball MD, and I'll see you guys in the next video.